Welcome to another episode of Cutting Edge Health. If we haven't met, I'm Dr. Orlando Landrum. I'm a Harvard-trained physician that helps patients understand their options for being able to deal with pain, whether it's physical or mental, and how to be able to live your best life, both pain-free and as long as possible. Today, what we're going to talk about is whether an epidural steroid injection is really the option you should choose as a first injection for trying to be able to deal with pain relief. As you could probably guess from the question, if I'm posing it, then yeah, no, it's not. But let's give you the reason and rationale. So let's take a look at the spine first. When we look at the spine, we know that there's a number of different things that are in place that can be problematic. So you can have a normal disc and it can have issues, whether it's degenerative disc, bulging disc, herniated disc, thinning of the disc degeneration, osteophyte formations, all of which can have some degree of pain. And I know I'm going through that really relatively fast, but we've talked about this at times before. And if we have not, you should watch those videos because they're pretty darn good. But let's say that you haven't. Most of the time people will get an MRI and they say, oh, okay, there's something going on with the disc. There's either narrowing or there's a bulge. And so we must do something about the bulge. Traditionally, the thing to do is they'll get sent for physical therapy, maybe chiropractic care, maybe possibly some traction, those type of things. But normally it's going to talk about having an epidural steroid injection. So an epidural steroid injection, most people think it's the same as a labor epidural. It's not. It's completely different. There are three different types of epidural steroids that can be done. What are those? They're the following. So you can have an interlaminar, you can have a transforaminal, and you can have a caudal. So right now, that probably means gobbledygook to you, but we're going to explain to you exactly what that means. So if you were to take a look at the cartoon representation that's up right now, it shows the following. You can be able to see in the top right-hand corner, a transforaminal approach, the bottom, a traditional translaminar approach, and the one off to the left, a caudal. So what does that look in actual real time? What it looks like is the following. If we were to kind of take a quick look, it looks like if this is the model, you can see that this type of approach like this is that translaminar approach, right? Which is similar to like what obstetrical labor epidural would be, where it comes right in the middle. I can tell you the vast majority of pain docs don't do that. So if you were to do a traditional epidural, it's going to be an epidural that centers in and around the region here, which is a transforaminal approach. If you can notice that and you can see that zoom in, it's in and around that nerve root that's present right in that region. And one of the reasons why is because that's where you have the pinch/squeeze, or at least so it's believed. But that nerve root presents its own problems and issues. And then finally, one of the other ways to be able to deal with this is to be able to come into that area in that region where you can kind of see this notch that's present, which is actually that component that sits right here, right? And so that's the sacral hiatus. It's a way to be able to get into and give medicine and see if it can spread up. There's a number of docs that do it. I would say its prevalence and incidence isn't as great as the transforaminal approach, but it might be able to give you some degree of benefit. The question is does it work? And for many people, it does. But the question is how long? So let's talk about that. We take a look at a previous type of technique that we reviewed before. That's called MILE, standing for minimally invasive lumbar decompression. They looked at epidurals. And they looked at if someone got one epidural or they got multiple epidurals, how well did it work? Which, if you've had that experience, traditionally old school docs will say, oh, you know what, we're going to set you up for a series of 3, which is frustrating, annoying, and problematic for me because historically the reason for the series of 3 is not because there's any scientific grounding and basis, but more so because insurance originally would pay for 3 years ago. And it influenced docs to say, well, you know what, we should just schedule 3 because we know we can get paid for 3 and then we'll come back, which doesn't really make any degree of sense. But anyway, let's talk about like how this is when we put a fine tooth comb to it and a magnifying glass. So when we look at it, we can be able to see that this study looked at kind of a breakdown of what happens with patients and what's going on. Most of the time, there is a herniated disc or bulging disc, and we can see this in terms of that 73% and 83% breakdown. And then we can be able to kind of deduce that there's also herniated disc, but there's other things that are going on. There's arthritis that's happening. There's other hypertrophy of the area that's present. There's foraminal narrowing that's in place. There's lateral recess narrowing, which is kind of this area of lateral stenosis. There's degenerative disc disease, which is the DDD. There's osteophytes, and there's other things that are happening. So what am I saying with that? The steroids don't improve the other things, and they may not improve the disc bulge. And clearly that's represented by this graphical representation shown here. So what we can be able to see is that this picture was an evaluation of looking at one epidural, which is in blue, or multiple epidurals, 2 or more, that are present in orange. And although you get an improvement initially for that first week, you frequently don't get much more improvement after that. Now, each person's different. And that doesn't always mean that you're not going to necessarily get improvement. But time over time, consistency, when we look at this from a statistical evaluation, traditionally, epidurals are at best a temporizing solution. So what's the normal solution in the pathway after that? Surgery, which most people traditionally don't want. So they'll say, oh no, we're going to send you for physical therapy, and they will. But traditionally, physical therapy post-epidural doesn't necessarily work. It may work prior to an epidural if it's disease isn't that severe and you can be able to improve some things. But post-epidural, it's normally not that effective. So do epidurals have problems and issues? They do. So what are some of the risks and problems? The following. So you can have flushing of the chest, you can have vasovagal changes, you can have temperature, you can have sleeping problems, you can have changes in the menstrual, water retention, anxiety, pain that is present at the site that can last for a period of time, allergic reaction, infection, nerve damage, numbness or tingling, bruising or abscess, temporary pain. You can have changes that are present in cortisol, you can have changes that are present in blood glucose, particularly for diabetics. So with all that, is it better than placebo? Hopefully. Well, this paper looked at this. So epidural steroids compared to placebo and whether it makes a difference. And one of the things that they found is that for many patients, when you take a look at the longitudinal evaluation at a 3 and 6 month time frame, it's not better than placebo. I know that there's many pain groups and other pain docs who would push back on that. They're like, well, hey, first of all, local anesthetic's not going to last that long. We know that. But then when we use steroid, shouldn't we have some degree of impact that's going to be longer lasting, particularly when you compare it to oral utilization? And historically, it's not. It really doesn't give you that long-standing relief like we'd expect. So are there other targets that we might want to consider before we're doing an epidural? And one of the main reasons why is because epidural failure, surgery. No one really wants surgery if you don't have to. One of the things to consider is possibly the SI joint. So we've talked about the SI joint in other lectures and other videos, and we know that it sits at that area that's in and around that sacral hiatus and the components that are present with the sacrum and the ilium in presence. But the fact of the matter is, SI joint pain is probably one of the least diagnosed problems. And you very well may have SI problems in addition to or be the primary issue and it hasn't been evaluated. So why do I mention this? Well, sometimes it's missed so much that it's not present in someone has had back surgery. So there's one paper that looked at the incidence of SI joint pain just as a whole, as persistent back pain, and they thought it's somewhere around 30%. So maybe give or take on average, roughly around 1 in 3, right? But what they also looked at was, could fusion potentially cause problems? And one of the papers that looked at this was a CATS paper that saw that after having surgery, they thought that somewhere around 14 to 22% of people actually resulted in having SI joint pain. And there was another paper that looked at this and they found that there's an incidence that in essence ranges between 10 and 12%. So 1 out of 10 people that have had back pain and have had, that have had surgery, more than likely had an epidural, then went to surgery, and then that surgery potentially caused them to have an SI joint problem because there's changes in biomechanical components of the spine and adjacent segment disease that can make SI joint pain be worse. But they may have had it beforehand. So at the end of the day, what the heck am I saying? Take the medicalese away and explain this. To do an SI joint injection, it basically looks like the following. If we were to take a look at this model, we can see this is the joint that sits right there, right in the center of your screen. And if we were to come in and we were to bring that area of this pen that sits right there, we're able to place medication in a similar way that we would with an epidural. So what's the benefit to it? It's easier, it's quicker, it's faster for you. The likelihood that you're going to experience discomfort with an epidural is moderate. The likelihood you're going to experience discomfort with the aspect of an SI joint, minimal to almost none. So if you can be able to circumvent this problem that you have of pain and pain that's going down your leg, because SI joint pain can go down the leg. If your doctor tells you different, you should look at one of our videos that talks about that. But that's neither here nor there at the moment. It's going to probably be easier, safer, faster, and it may curtail you finding out that you had a problem that actually preceded surgery that you got referred to because your epidural didn't work. If videos like this provide you value, please hit the thumbs up. And if you want to learn other things that can help you be able to know how to be an advocate for yourself, how to take control of your care, and how to be able to lead the life that you deserve, whether you're dealing with physical pain or dealing with mental pain, and you want to be able to lead a long life that lets you be able to enjoy every minute of it, sign up for our channel. Thank you so much and have a great day.